Okay, heart failure. I don't know exactly how long this recording is going to be. I do have a couple of video clips, and based on my experience with some previous attempts, I just can't seem to make the video clips pop up. So I'm just going to end up loading those video clips separately in this same folder so that you can, pause this YouTube video and then go to the video clip and then back to the YouTube video, if that works for you. Or you can listen to the presentation and then watch the video clips. So heart failure. Heart failure is an abnormal condition, and basically what we're talking about is the heart doesn't pump correctly, or it doesn't fill correctly, or both of those. Keep in mind that heart failure is not a disease in and of itself, but rather it's a syndrome. There are a few things that can cause heart failure, but it's particularly associated with high blood pressure and with coronary artery disease. In heart failure, the heart cannot pump enough to meet the metabolic needs of the body. There are about 5 million people in our country that are affected by heart failure, and it is the most common reason for hospitalization in adults over the age of 65. Okay, now we're going to talk about causes. And causes, we can put them in two broad categories. Namely, we can say a situation that either acutely or chronically damages the heart muscle. And when that happens, it is not able to contract effectively. So that would be one broad category. Another broad category or precipitating factor would be a situation that prevents an effective contraction when the heart would otherwise be able to. So in the absence of a particular situation, the heart muscle is adequate, but because of a particular situation, it doesn't work like it needs to. Okay, causes of acute heart failure. And both the causes of acute heart failure and the causes of chronic heart failure can be divided into those two broad categories. And what you see here, now let me find my pointer. There we go. I guess I'll do this one. Wherever you see these things, those things are referencing situations that prevent effective contraction when the heart would otherwise be able to. And so basically, they correlate, see here? Okay, so those things go together there. So, acute myocardial infarction can cause heart failure. Pulmonary emboli, hypertensive crisis, myocarditis, papillary muscle rupture. These can cause acute heart failure, and they actually have an effect on the myocardium, causing it not to be able to contract effectively. In dysrhythmia, thyrotoxicosis, angina, and infection, what you're looking at is precipitating factors of acute heart failure that if you remove the infection, the angina, the dysrhythmia, then in the absence of those moments in time, then the heart beats effectively. Chronic heart failure, of course, now we're looking at things that kind of affect the heart over time. Again, coronary artery disease produces chronic ischemia, potentially. High blood pressure, we will talk more about that in a bit, but basically you're looking at the blood that the heart has to pump against being elevated over a long period of time, and the heart has to generate a certain amount of pressure to overcome that blood pressure. Valve disorders, you've got valves in the big vessels, the aortic valve, the pulmonic valve, and the left ventricle has to pump the blood through the aortic valve. The right ventricle has to pump the blood through the pulmonic valve. And if those valves get stiff or fibrotic and they don't open like they should, then there's a lot of pressure that the heart has to generate to overcome that. Or, also if the valves don't close correctly and blood backs up into that chamber behind the valve, whether it be the great chambers or the atria, then those chambers become overfilled and cause the heart to stretch and can cause heart failure over time. Congenital heart disease, you talked about those already and should have a pretty clear idea about how they affect heart failure. Cor pulmonale is a respiratory problem, and you will talk about that. Should be somewhere in the respiratory unit. I know I talk about it with respiratory failure, but I believe it comes up prior to that. But what happens in cor pulmonale is you have right-sided heart failure without left-sided heart failure. In truth, the most common reason for right-sided heart failure is left-sided heart failure. But in cor pulmonale, the problem is in the lungs because COPD produces pulmonary hypertension. Just think about what that means. Pulmonary hypertension, high blood pressure in the pulmonary blood vessels. What heart structure has to generate pressure to overcome the blood pressure in the pulmonary vessels? Well, it's the right ventricle. So in cor pulmonale, you have right-sided failure, but the left side works fine. The problem, though, in cor pulmonale is if the right side can't pump effectively through the lungs, then the left side doesn't get enough volume. Anemia, a chronic anemia can overwork the heart. Constrictive heart disease happens when the pericardial sac becomes thick and doesn't stretch like it should, and it constricts the heart. That's a chronic condition. At some point, the treatment of that constrictive heart disease is to remove the pericardium, at which point the heart then does quite fine. Cardiomyopathy, that's damage to the heart muscle, produces a chronic heart failure. So if we consider comparing our heart to this donkey and our body to the wagon that this donkey has to pull every day, well, a healthy heart is like an energetic donkey. Without fatigue, pulls the wagon full of weights. On the other hand, a diseased heart will have trouble meeting metabolic demands or pulling the wagon. Heart failure can be caused by interference with the normal mechanisms that regulate cardiac output. If we look at this determinants of ventricular function here, contractility, preload, afterload, those all affect stroke volume, which affects cardiac output. And then we have, as other predeterminants, heart rate, and then some structural functions of the heart itself. So, to say a little bit more about that, stroke volume is affected by preload, afterload, and contractility. Preload is the amount of myocardial stretch at the end of diastole, and it's based on Starling's law. So preload is the amount of myocardial stretch, and that stretch is produced by volume. So the preload is the amount of volume that comes in through the right atria, into the right ventricle, eventually into the left ventricle, okay? And what Starling's law says is that the more you stretch the myocardium, the bigger rebound you get, kind of like a rubber band. Another thing, though, to know about rubber bands, there is a limit to how much stretching you can do. If you continue to stretch and stretch and stretch a rubber band, it gets kind of, I don't know, boggy, is that the word? It loses its elasticity, it gets all kind of stretched out. Well, that happens when the heart becomes overstretched. If you remember back from anatomy and physiology, you have these actin and myosin filaments that catch each other, and you know, the heart muscle cells kind of have to overlap a little bit, and then they kind of like the gears on a wheel, they catch each other to pull forward. That's best demonstrated with my hands, which I'm sorry I can't do right now. But if you overstretch the heart, then the myosin and the myosin and actin filaments don't even catch each other to cause that contraction. And so you end up with a heart that doesn't pump well. Afterload is the resistance that needs to be overcome for the heart to eject its blood. Sorry, there was a half yawn in there. There is an inverse relationship between afterload and ventricular function. You know, as the resistance to contraction increases, the force of contraction decreases, which ends up decreasing stroke volume. Also, when you have an increase in resistance, you need more oxygen to supply the heart muscle. So afterload, think about how you measure afterload. And what afterload are we talking about? Well, for the left ventricle, afterload is the blood pressure in the aorta, which ideally is about 120/80. So that's the normal pressure that left ventricle is supposed to overcome to move the blood out. Now, if my blood pressure is 180/120, that's a lot of pressure that the heart has to overcome to squeeze the blood out of it. On the right side, just for a basis of comparison, the pressure in a pulmonary artery is about 25/10. That might even be a little on the high side. So the right ventricle is really only used to generating enough pressure to move blood through vessels that have a pressure of about 25/10. Now, contractility, that is the inotropic state of the heart independent of preload and afterload. So that one kind of speaks ideally to how healthy is the heart muscle. And then synergistic left ventricular contraction, that's where the right side and the left side are contracting together. Wall integrity, that's just speaking to the idea that you don't have a hole in your septum. And the competence of valves, you know, namely they close when they're supposed to, they open when they're supposed to, all those will affect cardiac output. So if we talk about left ventricular dysfunction, that is defined as an ejection fraction less than 40%. I'll define ejection fraction a little bit more down the road. The number one cause of left ventricular systolic dysfunction is loss of heart muscle because of heart attack. Pressure overload because of uncontrolled high blood pressure is another major cause of systolic dysfunction. It is estimated that only about 25% of all patients who have high blood pressure are adequately treated. So there is a lot of pressure overload that produces left ventricular dysfunction. Impaired contractility also contributes to left ventricular dysfunction. It's usually because of drugs like alcohol or chemotherapy. You know, alcohol is a cardiotoxin. Volume overload from valve disease can also produce or contribute to left ventricular dysfunction. So in this slide you have volume issues, pressure issues, loss of myocardium, impaired contractility. Left ventricular dysfunction will cause cardiac output to go down, and when cardiac output goes down, your body is not adequately perfused. In addition, left ventricular dysfunction will increase the amount of blood left in the ventricle when the heart squeezes. Therefore, both end systolic and end diastolic pressures are increased. And when those pressures are increased, the fluid backs up and you end up with congestion in the lungs and the patient feels short of breath. If we look at the pathophysiology of ventricular failure, we can break that out into a systolic failure and diastolic failure, and it is not uncommon for patients to have both. In systolic failure, this is the most common cause of heart failure. The left ventricle loses its ability to generate enough pressure to propel that blood forward. And the hallmark of systolic failure is a decrease in the left ventricular ejection fraction, or a decrease in the ejection fraction, because generally when we're talking about ejection fraction, we do mean left ventricle. Here's a picture for you, and this is just shows you what ejection fraction is. Ejection fraction is the percentage of blood that is left in the ventricle when the heart has contracted. So the left ventricle starts at the end of diastole when it's completely relaxed. It has 100% of the blood in it. Then the ventricle contracts. Blood is ejected out. I didn't say that right. Okay. I said that ejection fraction was the amount of blood that's left, and that is not correct. Ejection fraction is the amount of blood that is ejected with each beat. And I know that. I'm just struggling a bit. So in this scenario here, you have an ejection fraction of about 60%, because with each contraction, 60% of the blood you started with is actually ejected. And that's a normal ejection fraction. Now, in someone who has systolic heart failure, the ventricle contracts, but only 25% is ejected. 75% remains. So then what does the heart do? You know, 25% of a certain volume is a lot less than 60% of that same volume. And your body is dependent on a certain amount of cardiac output. Ejection fraction is the stroke volume divided by the end diastolic volume. So I think I've got that right. So, you know, your stroke volume is this blood that's ejected. And so if your ejection fraction goes down, your stroke volume goes down. So then what the heart will do to compensate for that is, if I've got a smaller percentage of the total being ejected, the heart says, I wonder if I start with a bigger beginning. You know, my ejection fraction is only 25%, but if I increase the volume in my ventricle before it contracts, then 25% of a bigger number at least helps my stroke volume. And so that's one of the compensatory mechanisms that the heart will attempt initially. Of course, another one is heart rate. You know, cardiac output times SVR equals blood pressure. Cardiac output equals stroke volume times heart rate. Stroke volume is the amount of blood ejected with each beat. This person has a better stroke volume being ejected with each beat, assuming that both patients start that 100% is the same amount. Of course, it isn't necessarily, because maybe this is, let me think, 70 mils. But if I have 60% of 70 mils being ejected, that gives me a stroke volume. Let's see, 60% of 70 mils would be 42 mils. Okay. Now, if my ejection fraction drops to 25%, 70 mils times 25% is 12, let me do that again, times, 17.5 mils of a stroke volume. But I need to get up to 40, okay, to have enough stroke volume. So one of the compensatory mechanisms is to start with a bigger number here. So instead of starting with 70, if I have 110, and I pump out 25% of that, at least I'm almost up to 30 mils. So that's not a good thing. But anyway, I diverged there a bit. Ejection fraction is the percentage of blood ejected, the percentage of blood that was in the left ventricle at the end of diastole, the percentage that was ejected. That is ejection fraction. Normal ejection fraction is greater than 60%. Certainly, when patients get to 30%, they're at risk for other problems because we know that patients who have an ejection fraction of 30% or less, and some say 40%, are at higher risk for sudden death, and they get ICDs. Okay, diastolic failure. This is a little different. In diastolic failure, you have impaired ability of the ventricles to fill during diastole. Diastole is ventricular rest time. That's the time when the ventricle is supposed to relax. Usually, diastolic failure happens because of left ventricular hypertrophy. And left ventricular hypertrophy often happens because of high blood pressure. Here's a cross-section of the heart. You can see a normal left ventricle. And this is a hypertensive heart. This left ventricle has had to pump against a high pressure for a very long time, and so it hypertrophies. So in this thickness, a lot of times this thickness, instead of, you may have some cardiomegaly, you may have some heart enlargement, but the thickness also goes inward, and it makes the chamber on the inside smaller. 20 to 40% of patients with heart failure have diastolic failure, and diastolic failure creates problems with pulmonary congestion, pulmonary hypertension. It's related to ventricular hypertrophy, but you will see normal ejection fraction. So you look at echoes, and these are the patients who are in with heart failure, and they have an echo, they have an ejection fraction on their echocardiogram that's like 70%. Now, it is not uncommon to see patients who have a mixed systolic and diastolic failure. You see this in dilated cardiomyopathy. The patient with dilated cardiomyopathy has a very poor ejection fraction, and they tend to have biventricular failure. So here's a normal heart, and here's a dilated cardiomyopathy. Now just take a look at this heart. Look what's happening to the valve leaflets. See how they're being stretched apart? And so when the ventricle does contract and it forces blood up, the spacing here is wider. You know, see how wide that is compared to the normal heart? And so the valves, just because of a structural stretch, don't close as well as they should. All right, some of the compensatory mechanisms. These compensatory mechanisms occur when the pressure in the heart chamber, especially the left ventricle, is elevated over time. Initially, the stretch increases cardiac output. That's a Starling's law thing. Eventually, though, that stretch is going to exceed the capacity of Starling's law, and then your cardiac output decreases. Hypertrophy, thickness, is an increase in the muscle mass and cardiac wall thickness in response to the overwork and strain. Just imagine that you go to the fitness center and you lift weights. You know, you use your arms to lift weights. Well, your biceps get thicker and they get bigger. Well, if your blood pressure is very high, the heart is pumping. Actually, it doesn't even have to be very high. It's just that if your blood pressure is high, the heart is pumping to move blood through that high pressure, and it's like lifting weights. So the ventricle gets thicker. The problem is that hypertrophied heart muscle doesn't always contract real well. Not to mention that hypertrophied heart muscle can make that ventricular chamber smaller, can make it harder for you to have a good end diastolic volume. So your stroke volume goes down because you don't start with a good volume. Increased sympathetic nervous system stimulation is often the first mechanism, but it's also the least effective. Okay? to try to compensate. When the cardiac output goes down, epi and norepi are released by your nerve endings. They increase heart rate, and they increase contractility, and they increase peripheral vascular resistance. Initially, that helps to improve cardiac output, but eventually it makes the heart need more oxygen and it makes the heart work harder. Now, as we talk about some of these things, the treatments for heart failure are often meds used to counteract some of these compensatory mechanisms that have gone awry. When the heart doesn't move blood effectively, the juxtaglomerular apparatus in the kidneys, they sense that decreased blood flow through the glomerulus. Renin is released. You get that whole angiotensin 1 to 2 conversion. When angiotensin 2 is sent out, you have impressive peripheral vasoconstriction, which of course now makes it even harder to pump the blood out, and also aldosterone. Angiotensin 1, angiotensin 2. Angiotensin 2 is released, and it stimulates the adrenal glands to release aldosterone. Aldosterone is a hormone, and when aldosterone is released, your body will conserve sodium. And in addition to conserving sodium, the body hangs on to water. So this whole renin, angiotensin, peripheral vasoconstriction, aldosterone stimulation that occurs because the kidneys aren't getting their fair share of blood flow is a wonderful idea if you're dehydrated or bleeding to death. But you see, your kidneys are not smart enough to know why they're not appropriately perfused. All they know is that they're not, and therefore it must be that you're dehydrated or you're bleeding to death. Now, in heart failure, of course, that's not the case. You're actually volume excessed, but your kidneys don't think so. They don't recognize it because the blood isn't going to the kidneys. So the kidneys are hypoperfused, and these triggers set in. There are various neurohormonal responses that contribute to ventricular modeling, and some of that ventricular modeling, remodeling is not good. In ventricular remodeling, the cardiac monocytes hypertrophy. Basically, you end up increasing the ventricular mass. You kind of change the shape, and in that it impairs contractility. The ventricles become larger, and they become less effective as a pump. Heart failure is a vicious cycle. In addition to maintaining normal cardiovascular homeostasis, the hormones and neurohormone system, well, I didn't talk about all of them, but you know, those systems play a pretty important role in compensating for decreased cardiac output. But it is known that over time, these same neurohormone systems will become detrimental and contribute to the progression of heart failure. So left ventricular dysfunction, cardiac workload is increased because preload and afterload are increased. Cardiac output is decreased, blood pressure is decreased. You get Frank-Starling mechanism, remodeling, you get the neurohormone activation. That causes cardiac output to go up because of increased contractility and heart rate, blood pressure to go up because of vasoconstriction and blood volume, but that increases cardiac workload because preload and afterload goes up. That makes it hard for the left ventricle to do what it needs to do, so you get dysfunction, which drops your cardiac output and your blood pressure, which Frank-Starling's mechanism is activated to try to increase that. You've got some ventricular remodeling going on. You've got hormonal activation. And then, you know, so anyway, it is a vicious cycle. If we look at heart failure, what we see, the neurohormonal responses to poor cardiac performance, initially they're adaptive. So in the short term, good news. But if it's sustained, then it has a deleterious effect. For example, salt and water retention. You know, if your kidneys aren't getting their fair share of blood flow, they're going to retain salt and therefore water. Short-term effect, improves preload. Long-term effect, pulmonary congestion and anasarca, which is general system water excess. You know, the person who looks like the Goodyear blimp because they got edema all over the place. The initial response of vasoconstriction is a good thing. It maintains blood pressure for perfusion of vital organs. However, on the long term, it exacerbates pump failure because it increases the pressure that heart has to pump against. It also increases the cardiac energy expenditure. Sympathetic stimulation increases heart rate and increases contractility or the ejection. That's good news in the short term, but in the long term, it increases energy expenditure and the heart pays a price for that. All right, components of heart failure. One-sided heart failure usually leads to both-sided heart failure. Left-sided is the most common form, and I've got your common causes identified here. In left-sided heart failure, cardiac output goes down, and in parentheses, another word or another concept of cardiac output is the forward flow of blood. And so when that happens, urine output goes down because the kidneys aren't being perfused. The heart rate goes up because, again, you're trying to preserve blood pressure, you're trying to preserve tissue perfusion, and if less is being moved forward, your body will try to move it more often. A high is SVR, which is the clamping down of your blood vessels, but at the same time, because the cardiac output isn't good, the blood pressure is low. The skin is cool and clammy because of the sympathetic nervous system stimulation. Blood pressure, blood and pressure, backs up to the left atrium into the pulmonary vein, producing pulmonary congestion and edema. I think I have a really good picture of that. Yep, I do. It's coming. So here's a cartoon guy. This is what left-sided heart failure looks like. Think about the left ventricle and what it's supposed to do. Left ventricle contracts, blood goes out the aorta, perfuses your brain, perfuses your kidneys, perfuses your feet, perfuses your gut, you know, just forward flow, okay? So when that doesn't happen, blood backs up. And think now, what's behind the left ventricle? Well, going backwards, behind the left ventricle is the left atrium. Behind the left atrium are the pulmonary veins. Behind the pulmonary veins is the lung, the alveolus, you know, the capillary. And at that point, you get leakage of fluid, okay, and that's what produces pulmonary congestion. Now, the pulmonary congestion is often worse at night, and you end up with paroxysmal nocturnal dyspnea. You know, in the night, the patient lays down and fluid collects, and then suddenly they're suffocating and they can't breathe. Elevated pulmonary capillary wedge pressure, that just reflects the volume in the pulmonary system. We can measure it with hemodynamics. In the worst case scenarios, you may see blood-tinged sputum. You see weakness because the body's not being well perfused. That goes with fatigue. You have a cough because the alveolus are irritated. You have orthopnea, or the difficulty breathing unless you're sitting up. Tachycardia, trying to make up for the decrease in stroke volume. Dyspnea when I exert myself. I may have, this is very end stage, but I may have cyanosis if I'm truly not perfusing my organs. And then decreased urine output, because if I don't perfuse the kidneys will do everything they can to conserve water, and they won't let you eliminate it. Right-sided heart failure results from a diseased right ventricle. The main cause is left-sided heart failure. Let's follow that on past some more. Remember, I said that as the left ventricle is not propelling blood forward, you get backup. of blood from the left ventricle to the left atrium, from the left atrium to the left vein, from the veins, left vein is not right, but from the veins, pulmonary veins, and then at the pulmonary veins, now you've got a capillary, and on the other side of the capillary, now you've got an arteriole. And in that capillary bed, between the arteriole and the venule, an alveolus lives that communicates gases across with that capillary. On the other side of the capillary now you have that arteriole, which connects to an artery, which I'm still going backwards, is now taking me to the right ventricle, the right atrium, and then the body. So if my left side can't pump blood forward, eventually the right side becomes overfilled. So that's why the primary cause of right-sided heart failure is left-sided heart failure. Now I mentioned cor pulmonale, and that is right ventricular dilation and hypertrophy caused by pulmonary pathology. So the left side's okay, but there's problems in the lungs, increasing the pressures in the lungs, and the right side fails because of it. And in this scenario, blood, and therefore pressure, backs up to the right atrium and into the venous circulation. Again, think about the right ventricle and where it sits anatomically. If it is not pumping blood forward into the pulmonary system, then blood backs up. Don't ever think that blood pumps backwards. I don't want you to think about that. But think about a traffic jam because there's an accident. You've got a 3-lane highway and 4-lane highway, and 3 lanes are shut down because of a traffic accident. Well, the total movement of cars is still in one direction because you do have that one lane that's open. But as more and more people get on that highway, there's a backup of cars on the highway, backing up and backing up and backing up. The net movement is still forward, but the forward flow isn't enough to accommodate all the cars that are getting on the highway. That's kind of how that works. Now, if the right side fails and you don't have appropriate forward flow, then you end up with left ventricular hypovolemia, because if the right ventricle cannot pump the blood through the lungs, guess what? The left ventricle has nowhere else to get blood except from the right side of the heart through the lungs into the left atrium, left ventricle. So when the right ventricle doesn't pump forward effectively, that patient can actually have left ventricular hypovolemia. Again, the primary cause of right-sided heart failure is left-sided heart failure, so you typically see these problems together. Here's the little lady with right-sided failure, and what you're going to see predominantly in her is peripheral congestion. Increased peripheral venous pressure, her neck veins are distended, she's got hepatomegaly, splenomegaly, she's got GI issues because of the swelling, she may have ascites, and she's got edema in anything that is dependent. All right, acute decompensated heart failure. Here is a picture of pulmonary edema, and when I was talking about blood moving backwards, okay, you know, let me just, I guess, just pick B, okay, because it's in the middle of the page. Over here would be the left atrium, okay, left atrium off of this. And then below the left atrium, left ventricle. So if I go backwards, this is a pulmonary vein, pulmonary venule, arterial pulmonary, you know, arteriole pulmonary artery, and then here's the alveolus that is communicating with this capillary unit. So this is a capillary alveolar unit, and you get gas exchange that comes across. Okay, so this is a normal-looking one, and you know there's some proteins here. And then as heart failure progresses, and you have blood not effectively being pumped forward, you get this backup of blood in the lungs, and then from the capillaries, fluid starts to leak into the interstitial space. So this is the interstitial space. And then the interstitial space becomes overwhelmed, and you start getting some movement of fluid into the alveolus, and in this picture you see the alveolus quite overcome with fluid. The problem with fluid in an alveolus is that oxygen does not diffuse through water very well. Carbon dioxide's not hard. It's about 20 times more soluble in water than is oxygen. So getting the CO2 out is not nearly as hard as getting the oxygen in when you've got a lung full of fluid, hence the problem. So, symptoms then of acute decompensated heart failure, you will see in the clinical setting, you will see the patients in with CHF exacerbation. That's still old terminology. It should be ADHF, acute decompensated heart failure. And patients have heart failure, that is the old term CHF. And then they have ADHF, which is the old term CHF exacerbation. So pulmonary edema, symptoms of pulmonary edema are agitation because you're not getting oxygen where it needs to be. They can be pale and cyanotic. The sympathetic nervous system causes them to have the cold, clammy skin. They have severe dyspnea, tachypnea. They have crackles all over the place. If they have wheezes, you're actually maybe in a better place because wheezes mean narrowed airways, where crackles indicate that you've got water now in those alveolar spaces. Frothy blood-tinged sputum, tachycardia, trying to compensate for the lower oxygen. And then you might have a high or a low blood pressure. Okay, low blood pressure if this is going on and the oxygen needs are not met. Higher blood pressure may be because of all the pressure in the vasculature system from all that extra fluid. Chronic heart failure, not congestive heart failure. We say chronic heart failure. That's the same thing that you see in a clinical setting when they say congestive heart failure. Chronic heart failure, the symptoms are due to a couple of things. Namely, you get poor forward flow from the left ventricle, so you've got a problem with organs being adequately perfused. You've got an energy problem. And then you've got a problem with backup of pressures, and that results in fluid leaking into interstitial spaces. If the left ventricle backs up, just think about your anatomy, you're going to have lung problems. Problem with extra fluid in the lungs, in that alveolar capillary interstitial space, and then flooding the alveoli. When the right ventricle doesn't pump forward and you back up, you get peripheral backup. Just think about the anatomy. So in chronic heart failure, you have symptoms of fatigue, dyspnea, in particular paroxysmal nocturnal dyspnea. One of the things that happens at nighttime for patients with chronic heart failure, during the day when they're up, just think about your heart and the way it moves fluid. Do you think it is easier for the heart to move fluid when you are perpendicular or when you are, I hope I'm saying this right, when you're standing up and down, that's what I mean by perpendicular, or when you're horizontal, like you're laying in bed? Well, actually it is easier to move blood when you're horizontal. When you're perpendicular, there's a gravity thing going on. So patients who have chronic heart failure during the day tend to develop peripheral edema. You know, extremities that are down, lotta. Then at nighttime, when you become more horizontal, then the fluid from the interstitial spaces goes back into the vascular space, and that can cause a sudden change, namely increase in the blood volume, and the heart can't handle that extra, and the volume or the water ends up dumping into the lungs. Now, any of you that have had children or had any issues while you were pregnant with fluid gain, your doctor would say to you, you need to rest. Like you need to be in bed, laying down, doing nothing. And that's because if you would do that, then when you're horizontal, it's easier for the fluid to go back into your vascular space. Of course, because you're young and healthy, you're just pregnant. The heart, when it becomes aware that you've got this extra fluid on board, it just pumps it to your kidneys, and then you have to get up and go to the bathroom. Well, in the patient with chronic heart failure, their heart doesn't pump it forward very well. It just dumps into the lungs, going backwards instead. Tachycardia, to make up for the decreased stroke volume. Edema, as I explained. And then nocturia, okay? Not every patient is going to have PND all the time. Sometimes the heart actually does pump it down to the kidneys, and the kidneys do respond by making you get up and go to the bathroom. Behavior changes. That's because blood isn't pumping adequately to your brain. Sometimes patients have chest pain. Weight changes, obviously. Skin changes, can become kind of dusky in appearance. Okay, now we're going to talk about complications of heart failure. Pleural effusion, the extra water, extra pressure can allow fluid to leak in the pleural space, that's the lining around the heart. A couple of things happen when you have a pleural effusion. The lung can't expand as well into that area, so you decrease, the area for oxygen transmission. The pleural fluid can become kind of sits there, and there's a tendency for bacterial growth or potential for. Dysrhythmias is another complication. Over time, as the heart muscle's been stretched, the normal conduction pathways and cells can get a little messed up. Left ventricular thrombus, if the ventricles are not propelling blood forward very well, and you got sluggish blood flow through the heart, blood sits in the ventricle, and you can have clot that forms along the walls. Hepatomegaly, just think about the backup. If the right side of the heart is backing up into the right atrium, then you have the superior and the inferior vena cava, and one of the next things that happen is the liver is congested. Kidney failure can happen when the heart chronically doesn't pump blood forward to perfuse the kidneys. And then cardiogenic shock is an end-stage state where the heart absolutely does not meet the metabolic demands of the patient, and the patient becomes shocky. There are a couple of different ways of classifying heart failure. The New York Heart Association classifies it based on a person's tolerance to physical activity. So they have, class 1, class 2. You can see that in class 2 you have some symptoms when you have some physical activity, but no symptoms at rest. Class 3, you're significantly limited, and usually you're comfortable at rest, but just ordinary things will produce symptoms. And in class 4, this person can't carry on physical activity without discomfort, and they can have symptoms even at rest. Any physical activity then will increase their symptoms. The other way of classifying heart failure is the ACC-AHA classification, and these are based more on objective measures, risk factors and subjective symptoms, so it's a little bit different. In a stage A heart failure, the person is at high risk of developing LV dysfunction. So stage A, there's no actual heart failure. This would be a person, for example, who has hypertension. In stage B, there's a structural problem, but no symptoms. You can actually see that something's wrong with the heart, but the patient is not symptomatic. In stage 3, you have symptoms with underlying structural heart disease. In stage D, you have advanced structural heart disease, and you have marked symptoms at rest despite maximal therapy. So in stage D, we've done everything we can. That's kind of a terminal state. So if we consider diagnostic studies, the primary goal is to identify an underlying cause and address it if we can. So they'll do a physical exam, they'll look at chest x-ray, EKG, hemodynamic assessment, what's the blood pressure, what's the pulse. If they have, invasive monitoring, what are the pressures in the various chambers. Stress testing will be done to identify if ischemia is a component. They'll do a cardiac catheterization, again, to see if there is a problem with the coronary arteries not adequately perfusing the heart muscle. They can also check pressures in the various chambers, and they can get an ejection fraction measure in a cardiac cath. You can also do diagnostics to assess the degree of heart failure and the response to treatment. So you can do echocardiograms, you can measure the ejection fraction, and then that brain natriuretic peptide that we talked about, that's one of the most common uses of BNP is in the patient who comes to the emergency room with shortness of breath. Is it their heart or is it their lungs? If the BNP is elevated, we know that at least in part the heart failure is related to, the shortness of breath is related to the heart failure. So something less than 100 pgs per milliliter is normal. So basically, when they draw this lab in the ER, if it's less than 100, it's very improbable that the shortness of breath is cardiac related. Between 100 and 500, heart failure is rather probable, and greater than 500, heart failure is very probable. The amount of elevation can correlate to the degree of LV dysfunction, but I'll tell you that in practice, I don't always see that bearing out because there's another component to BNP, namely the BNP is eliminated by the kidneys. So if you've got some kidney impairments and or, just by virtue of having heart failure, your kidneys are retaining and not perfusing. So there's a little bit of an, problem there. It's not a straight line linear relationship. It's not a straight line or not a perfectly linear relationship. I mentioned that we use it to differentiate the cause of shortness of breath. And then one of the things that we do know is that if a person's BNP does not rapidly return to normal, they have a high risk of mortality associated with their heart failure. So what is it that we do when the patient comes into the emergency room and they have an acute decompensation of their heart failure? Now, this is an overall look, and we're going to break these things down in subsequent slides. The nursing and the collaborative management, the primary goal is going to be to improve the left ventricular function. Regardless of the cause of the acute decompensated heart failure, it will manifest as pulmonary edema. Okay, it can be life-threatening. These alveoli fill with serosanguinous fluid, and you don't get adequate oxygen crossing the alveolar capillary membrane. So what do? We're going to do what we can to decrease intravascular volume. We'll say more about that. Decrease venous return, decrease afterload, control heart rate and rhythm, improve gas exchange and oxygenation, improve cardiac output, reduce anxiety, and preserve your target organs like your kidneys. So, decreasing intravascular volume, just what does that mean? Well, first of all, it helps by reducing venous preload. If we can decrease the intravascular volume, then the amount of volume that goes back to the heart is reduced and the heart doesn't have so much to deal with. So the way we do that is fluid restriction. The loop diuretic is the drug of choice. We're talking about furosemide. Oh, by the way, another loop diuretic that can be used is bumetanide. That's Bumex. It has the same ending as furosemide, and just for your purposes of understanding, 40 milligrams of Lasix is a pretty common dose. 40 milligrams of Lasix in terms of potency equals 1 milligram of Bumex. So when you see Bumex dosed, it's 1, 2, 3, or 4 milligrams. You see Lasix, it's 40, 80, that kind of stuff. So when you're giving 4 milligrams of Bumex, that's like giving 160 milligrams of Lasix. And yes, they are both potassium depleting. Calcium and magnesium depleting also, but mainly potassium, or mainly we worry about potassium. Okay, additional things that we can do to reduce venous return besides decreasing vascular volume, and how that helps is that when we decrease venous return, we reduce the amount of volume returned to the LV during diastole. Okay, very similar to what we do. The same thing. If we decrease intravascular volume, we decrease preload. Okay, so a high Fowler's position promotes pooling of blood in the extremities. And you're thinking to yourself, well, that's crazy. Why would ever I want to promote pooling of the blood in the extremities? Well, when you don't want it all to be in the heart at the same time. In your body, there's really only 3 places. Let me think about this. There's only 3 places. Yeah, I'm right. There's only 3 places for blood to be in your body. It's in your arteries, in your veins, or in your heart. And if your heart is having difficulty dealing with the load, then we're going to do what we can to leave more of it outside the heart. IV nitroglycerin, Tridil, is the trade name of that, reduces prelude by vasodilating and making that venous space bigger. If the venous space is bigger, then less blood is in the heart at any given time. Tridil also has the additional effect. You've learned nitroglycerin when we did coronary artery disease, and what you learned about it was that it vasodilates coronary arteries and increases the oxygen supply to the heart muscle, and that's always a good thing. Because it is a vasodilator, it will reduce your afterload somewhat as well. Another thing about high Fowler's also increases your thoracic capacity and improves your ventilation. And then IV push morphine has more effect than just to deal with pain. It vasodilates, it decreases anxiety, and it reduces the subjective feeling of dyspnea. All those things help decrease the oxygen need. Decreasing afterload, the amount of wall tension that the left ventricle has to generate to eject its blood into the aorta, the amount of work that the left ventricle has to produce to eject blood is your afterload. The SVR is a determinant of afterload, as is left ventricular filling. So the things that we can do to decrease SVR, systemic vascular resistance, and decrease left ventricular filling will help decrease afterload. If we can decrease afterload and allow the heart to unload more effectively, we effectively decrease pulmonary congestion. You learned about IV nitroprusside when we talked about hypertension, potent vasodilator, ACE inhibitors, and morphine sulfate. Improved gas exchange and oxygenation. Giving morphine decreases the oxygen demand because it decreases your anxiety. It does some vasodilating, so you just don't need as much oxygen. And in a condition where your body's having a hard time providing it, it's good not to need as much. Giving oxygen. And then, if we're not making progress and we need to, sometimes we have to intubate and provide mechanical ventilation because a bad heart cannot even handle the work of breathing. To improve cardiac function. Now here we're actually looking at what can we do to actually affect the heart muscle itself. Dobutamine is a selective beta-2 agonist. It does not increase your systemic vascular resistance. Now, my notes say it's a beta-2 agonist, but my brain is telling me that that's not right. Let me check on something. Well, it's always good to know that my brain is better than my notes. Dobutamine is a selective beta-1 agonist. Now, an agonist is something that stimulates it. It's not the same as an antagonist, okay? Antagonist blocks or prevents. Agonist, goes there. So dobutamine is a selective beta-1 agonist, and you have beta-1 receptors on your heart muscle and in your conduction system. So giving dobutamine then allows the heart to pump more forcefully. It can increase heart rate as well. The thing about dobutamine is the only way to give it is IV. So if people's hearts are that bad, they can go on home dobutamine drips. A friend of the family, she was a young girl when she developed viral myocarditis. I want to say in her mid-teens, she was 15 or 16 when she developed viral myocarditis. It progressed to a cardiomyopathy. She eventually ended up with a heart transplant. I believe she was 23 when she got her heart transplant. But while she was waiting for her heart, one of the things they did try, she was on dobutamine in a PICC line at home. She was horribly, horribly sick, and really was probably within hours of dying when she did get a new heart. But I remember that she was on a dobutamine drip. Dopamine can also be used to improve cardiac function. It is a beta agonist. It also has alpha agonist properties. So dopamine is one of those medicines that has kind of varied ranges of dosages. When we infuse it at a very low dose, it's thought to have dopaminergic effect on renal receptors. Maybe it improves urinary output. We used to do a lot of renal dose dopamine. We don't so much anymore. But that was low dose, say up to 3 mics. And then somewhere between 3 and 5 mics, we got the beta agonist effect that improved cardiac output. And then when you get, somewhere 5 to 10 and certainly greater than 10, then you have an alpha agonist effect. And alpha receptors, remember, are on your blood vessels, and when you stimulate those, the vessels constrict, so increases your blood pressure. That's not so good for the heart because now you've increased the SVR. So dopamine, we want to keep that at the lower ends so that it has more of the beta effects. Milrinone and inamrinone are phosphodiesterase inhibitors. They are indulators, and those help with cardiac contraction. They enhance, by being indulators, they enhance calcium entry into the cells to improve myocardial contractility. Hemodynamic monitoring. A lot of times, if we've got people on these drips, we may have hemodynamic monitoring like a Swan-Ganz catheter. Although I would say we're doing less Swan-Ganz catheters because we've got much better, actually quite good, non-invasive means of measuring cardiac output. We didn't used to have that. Reducing anxiety. We're looking at IV morphine, and we want to maintain adequate tissue oxygenation. General objectives for drug management. We're going to look to correct sodium and water retention. We want to reduce workload. We want to improve contractility. We want to control precipitating and complicating factors. Diuretics, in particular the loop diuretics, but also the thiazide diuretics, they help to mobilize interstitial fluid, reduce preload, and reduce pulmonary pressures. Aldosterone antagonists, heart failure results in underperfused tissues and congested organs because of high angiotensin II and aldosterone concentrations. And, aldosterone is not a good thing for the heart. So, spironolactone has long been known, for its potassium-sparing diuretic effect. You guys all know that. But know it as an aldosterone antagonist. It is the only aldosterone antagonist available for clinical use in our country. Current guidelines, based on studies, recommend the use of aldosterone antagonist daily or every other day in patients with severe heart failure. The results of recent clinical trials have shown a pretty significant reduction in overall mortality rate when we use spironolactone daily in patients with moderate to severe heart failure. Now, you do know that we have to watch potassium. There's also some other side effects. About 9% of patients will develop gynecomastia because of the spironolactone. ACE inhibitor therapy is also pretty standard in heart failure, but I think that's coming. Oh, we do have a new medication. I don't know if I have it written, but there's a medication. The trade name is Inspra, I-N-S-P-R-A. The generic name is E-P-L-E-R-E-N-O-N-E, eplerenone. But that's a new one that's been out for about 4 or 5 years. Yeah, threw this picture in here. What diuretics do is reduce the number of sacks on the wagon. So that old tired donkey doesn't have to carry quite so much. ACE inhibitors. ACE inhibitors is a first-line medicine used in all stages of heart failure. All stages of heart failure. That means even without symptoms. We know that it decreases conversion of angiotensin 1 to angiotensin 2. By doing that, it decreases the systemic vascular resistance, basically your blood pressure. It also decreases the pulmonary vascular resistance. And it decreases plasma aldosterone. Those are all great things. It is a first-line med used in all stages of heart failure, even in patients who don't have symptoms. Now, the exact cause of a cough and or other intolerances have to be verified before the ACE inhibitor is discontinued. If you take an ACE inhibitor for high blood pressure and you develop a cough, the doctor may be a little quicker to switch you to a different antihypertensive medication. But if you're taking the ACE inhibitor as part of your heart failure therapy, then they really do need to make sure that it is the ACE inhibitor that's producing the cough, because it is that beneficial. Now, if you can't tolerate the ACE inhibitors, either because of a cough or angioedema, then the angiotensin receptor blockers work pretty darn well. Efficacy is pretty similar. I think they might be a little more expensive. The ARBs work by blocking the receptors that the angiotensin II would like to stimulate. So they get there first and they take up the space. A great drug is, if you can't tolerate ACEs or ARBs, okay, and that does happen. If you can't tolerate ACEs or ARBs, then a medication called Bidil, B-I-D-I-L, that's hydralazine with isosorbide dinitrate, can be used. Nitrates. They do improve survival in overt heart failure. They vasodilate, particularly veins, but they also vasodilate the coronary arteries to improve blood flow. They reduce the preload by vasodilating the veins. They improve the ejection fraction by reducing the preload, making it easier for the heart to manage. They decrease the heart size, and they avoid stimulating the neurohormonal response related to many of the compensatory mechanisms. I mentioned this one a little bit earlier. This is being used in African Americans who are already being treated with standard therapy. and they're having really good success. It is only approved for use with African Americans. The mechanism of this combination is not fully understood. The hydralazine relaxes arteries and decreases cardiac workload. You know, the isosorbide dinitrate relaxes veins as well as arteries, and it seems to work by maybe releasing nitric oxide at the blood vessel wall, but that effect usually wears off after half a day. Hydralazine may be preventing the loss of that effect. So, you know, there's some speculation as to what it is about that combination that makes this work. Beta blockers. Beta blockers. More correctly, they are beta adrenergic blockers, but it's okay to call them beta blockers. They decrease heart rate. That is the primary means by which beta blockers decrease blood pressure. They decrease myocardial oxygen consumption. That's what MBO2 stands for. And they do that by decreasing heart rate, because the faster my heart goes, the more oxygen it needs. It certainly doesn't hurt in this effort that it decreases the inotropic effect. You know, because if I'm squeezing less forcefully, I don't need as much oxygen. Beta blockers directly block the negative effect of the sympathetic nervous system on a failing heart. So what happens is that a failing heart stimulates the sympathetic nervous system, which stimulates the heart to beat harder and faster. But the heart really, that doesn't help, and so with overstimulation of these receptors on the heart, the receptors downregulate. They kind of disappear. It's like they hide. They tuck away so the sympathetic nervous system can't get to them. And by using beta blockers, you can block these receptors to give them a rest and allow them to upregulate, and then they can become more appropriately responsive. Beta blockers are routinely administered in mild to moderate heart failure and in a left ventricular ejection fraction of 40% or less. We start that in the hospital, assuming the patient has got normal volume and they're stable. It is as much a priority as the ACE inhibitor. It will be titrated regardless of whether the ACE inhibitor has reached target doses. You start gradually with the beta blockers. You dose it every 1 to 2 weeks. You go up as the patient's tolerating it. It's important to let patients know they shouldn't stop taking their beta blockers suddenly because they can get a rebound tachycardia. Beta blockers limit the donkey's speed, thereby saving energy. Digitalis. Digitalis is a cardiac glycoside. It is shown to reduce symptoms, but it's not been shown to prolong life. It is particularly useful in heart failure with aflutter or AFib, A being atrial. Particularly useful in heart failure with atrial flutter or atrial fib with rapid ventricular rate because it decreases conduction speed in the myocardium and it slows the heart rate. So it is a negative chronotrope. It slows the heart rate. And you know that because we always check an apical pulse when we give DIG. We instruct patients that they should contact their health provider, and if their heart rate is low, then they need to check with their doctor to see, what they should do next. This hard and fast rule about never give it if it's less than 60 is really not true. There is some variance there. Certainly, if a heart rate is less than 60 and you're the nurse, you're going to check to see whether the DIG should be given or not. You're going to hold it until you get an order or till you confer with the primary health provider about whether they should take it or not. It's a positive inotrope in that it helps the squeezing of the heart. So here is some pharmacology on DIG. It enhances the inotropy of the cardiac muscle. It reduces activation of the sympathetic nervous system and the renin, angiotensin, aldosterone system. In controlled studies, they have shown long-term DIG therapy reduces symptoms, improves exercise tolerance, makes your hemodynamics better, decreases the risk of heart failure progression, reduces hospitalization for decompensation, but does not improve overall survival. So it doesn't improve overall survival, but you do live a little better while you're living. This is an example of what it might look like to be on Dig. It just helps the poor little guy work a little better. For patients who are on Dig, you need to know, the therapeutic range is really, it's 1 to 2, but it's okay. 0.8, probably to 1.8. Do keep in mind, some patients will develop symptoms of toxicity as they near 2, depending on how big they are. Symptoms of toxicity, nausea, vomiting, anorexia, those are early symptoms. Your cardiac symptoms, the dysrhythmias, they tend to be late indicators of toxicity. If a patient is on Dig, it's very important to monitor potassium levels, because if potassium level is low, that will enhance the ectopic pacemaker activity. So low potassium makes it more likely for the patient to develop dysrhythmia. Neural symptoms, dizziness, disorientation, confusion, and then they tend to develop these yellow halos. Some inotropic drugs, beta-adrenergic agonists. This is not a blocker, okay? This is a stimulator. It's used in short-term treatment of the acute decompensated heart failure. I've got those listed there. And I think we talked about those a few slides ago. The inotropic drugs that are calcium sensitizers, there's one listed there. It's used in patients who are also at risk for myocardial ischemia. They increase the heart's sensitivity to calcium to improve its contractility without increasing the oxygen requirements. That's what makes those beneficial. You get increased contractility without increased oxygen requirement. These calcium sensitizers also have a vasodilating effect by opening ATP-sensitive potassium channels in the vascular smooth muscles. So they produce vasodilation, they improve contractility, and they don't cost more oxygen. Not yet approved. Calcium sensitizers are not yet approved in our country that I know of. Those things change fast enough that sometimes I'm not able to keep up. All right, some other medications used in heart failure. Trimetazidine is a metabolic modulator that improves cardiac function and glucose control in diabetic patients who have dilated cardiomyopathy. So that would be a special situation, a diabetic patient with dilated cardiomyopathy. Statins. Statins have been shown to increase survival, heart function improvement, and reducing the inflammatory markers in ischemic and idiopathic dilated cardiomyopathy. Now, why in the world is cardiomyopathy thrown in here? Because dilated cardiomyopathy produces a heart failure. It may be an entity in its own. As a matter of fact, the cardiomyopathy readings are in a different chapter, but it's easier to deal with them in heart failure because the symptoms of cardiomyopathy are very similar to heart failure. Anticoagulant therapy may be necessary. We want to prevent atrial thrombus or ventricular thrombus. Okay, atrial thrombus can happen in a patient's got AFib. Ventricular thrombus can happen because the ventricular chamber is enlarged and the blood's just not going through it very well and you get stasis. All right, BiV pacing. BiV pacing is very cool. A 5-year study was actually stopped after 2 years because the results were so positive. Biventricular pacing improves the efficiency of a heart by 25 to 30%. It's very cool. The condition of the heart muscle improves over time and the size of the heart regresses. Those are good things. There was a study where there was a 40% lowering of mortality in the BiV paced group. So what BiV pacing does is allows for something called cardiac resynchronization. One of the things that happens in heart failure is there's often bundle branch blocks that accompany heart failure because of the chronic stretching, and so the conduction system is just a little bit off. It's just a little bit enough off that the right and the left ventricle have like this millisecond difference in when they squeeze against the septum, and so there's kind of a sloshing of blood that occurs because of that. When you do bivalve pacing and resynchronization therapy, you have 3 wires. You've got an atrial wire, and then you have 2 ventricular wires. You have one on the left and one on the right, and the electrical impulse grabs the heart from the right and the left and squeezes it together so that the right and the left ventricle contract in a coordinated manner. Now, you probably think they always contract in a coordinated manner. Well, they're supposed to, but in heart failure that gets off a little bit, and they push asynchronously against the septum. Now, I have some videos of this concept that I am not going to even try to play, because I've tried and it doesn't work. But I will post those, and you need to look at the ventricular dyssynchrony. Look at the movement of blood and how things kind of slosh around in the heart when the right and the left ventricles are just a smidge off in when they receive the impulse to contract. And then with the cardiac resynchronization therapy, you can see the right and the left getting the impulse at the same time and squeezing very, very effectively. I think I have another video that will show the access to the left ventricle. That's different. If I look at this slide here, for example, here's my atrial lead. Okay, we drop it in the atrium. Remember, I said pacemaking wires have barbs. The right ventricular lead is also very easily accessed. You just drop it through the big vein being the subclavian up here, and then the inferior vena cava. You leave the right atrial wire in the right atrium. You drop the right ventricular wire into the right ventricle. Okay, you're good to go. The left ventricular wire, I got to think about this a minute. Yeah. They find a vein, a coronary vein, that travels along the outside of the heart. The lateral or the posterior lateral vein is accessed, and then the wire is dropped into that vein on the outside of the left ventricle, okay? Like right there. So I will post those videos in the same folder as this content so you can look at that, because it's really quite cool. That's where they would be if they were here. Cardiac resynchronization therapy then increases the donkey's efficiency. See, he's got roller skates now. And I'll tell you, for patients who've experienced dyssynchrony and they have resynchronization therapy, they feel like they've got roller skates on compared to how they felt before. All right, when all things are not working, there are some things that we can do while we're waiting for cardiac transplantation. For example, an IABP, that's an intra-aortic balloon pump. It's a short-term bridge to cardiac surgery. The patient has to be on complete bed rest. What happens is the femoral artery is accessed, and this balloon is placed in the aorta. It has to go up above the renal veins, because you certainly don't want to block the renal veins, okay? And it goes up before the bend, so right in this area. And so what happens is twofold. The balloon, when it is inflated, puts pressure on this and allows the coronary arteries to fill. So it'll be inflated during diastole to augment filling of the coronary arteries, and then just before the ventricle gets ready to contract, it very quickly deflates. And by deflating, it creates somewhat of a suction or a vacuum. And that suction or vacuum effect allows the heart to unload more readily. It's like it's helping to suck the blood out of the heart. I don't know if you can picture that or not. So balloon deflates very quickly, and the blood is kind of sucked out of the heart at the very same time that it's contracting. Then the balloon inflates, which puts a little increased pressure during diastole, which improves filling. Again, short term. What we are seeing more of are ventricular assist devices. They can stay in for months to years. They also produce a bridge to transplant. They can also be destination therapy. So here the pump is external, but the connection has to go through the patient's skin, and then it'll be tunneled, and then it's tunneled to a pump that facilitates the flow of blood. They poke a hole in the heart on this side, and the blood is pumped out of the left ventricle and into the aorta. So the ventricle isn't, the ventricle can beat, but that's not what's moving the blood. This pump is moving the blood. It sucks the blood out and drops it into the aorta. Sucks the blood out, drops it in the aorta, okay? Lots of care goes with those. All right. Continued collaborative care, the DASH diet. A severe restriction would be 0.5 to 1 milligram of sodium a day. Be sure you know your sodium foods, namely, your processed foods, canned foods, cured meats, dairy products. Those are high sodium. Mild heart failure produces a mild heart failure, the sodium restriction for that is 2.5 grams. Patients should weigh themselves daily, and they should notify their healthcare provider if they have weight gain of 3 pounds in 2 days or 3 to 5 pounds a week, especially if that weight gain is accompanied by dyspnea. Dyspnea and weight gain is not a good combination. Dyspnea should always be a concern, especially if it's more than their baseline. So this slide shows you the stages as classified by the ACC, American Cardiology, I don't know what the other C stands for, or the American Heart Association guidelines in the evaluation of heart failure and the recommended treatment. So, stage A, high risk, no disease. Stage B, structural heart disease, no symptoms. Stage C, structural heart disease, they have had some symptoms. And stage 3 is refractory, requiring specialized intervention. So we've kind of gone over these. Okay, look at the therapies. In stage A, treat blood pressure, treat lipids, encourage exercise, discourage alcohol, and consider ACE inhibitors. In stage B, everything in A, and then ACE inhibitors in appropriate patients, beta blockers in appropriate patients. In stage 3, we're doing everything that's in stage A, and we're adding diuretics, ACE inhibitors, beta blockers, DIG, and we're going to restrict sodium. In stage 4, we do all of this stuff, plus we may have to do a mechanical assist device, a heart transplant, continuous IV infusions of inotropic medications for palliation, and we consider hospice care. This is end stage. These patients are going to die. So nursing diagnoses to consider are listed here. It shouldn't be any surprise. Disturbed sleep patterns from the nocturnal paroxysmal nocturnal dyspnea that happens, from the increased urine output that happens at night. The rest, I think, are pretty self-explanatory. Our overall goals, big picture, decrease the edema, decrease the shortness of breath, allow the patient to get around a little better, make sure they understand their medications and that they don't experience complications. Health promotion. We want to be sure that we are educating our patients to prevent heart failure by controlling the underlying heart diseases like, coronary artery disease. And what does that all involve? Preventing coronary artery disease, treating, managing high blood pressure, taking care of heart valves. We want to teach regarding disease, medications. We want to make sure that patients know when they need to notify their healthcare provider, and then exercise training. Now, acute intervention, we want to manage the acute decompensation in heart failure. And remember, ADHF presents as pulmonary edema. Ambulatory and home care, teaching. There are psychological changes that occur in heart failure. The patient and family teaching guide that is in your textbook, table 35-15, would be helpful here. Exercise saving behaviors. If they've got really bad heart disease, they need to know how to conserve their energies. Medications. Considering the psychological changes, in your Class 3, Class 4, New York Heart Association, Class 3, Class 4, it is known that there is higher rates of depression and anxiety, more so in women under the age of 60. So for women under the age of 60, the research demonstrates that they have significant problems with depression and anxiety. All right, cardiomyopathy. Cardiomyopathy describes a group of heart muscle diseases that affects the structure of the myocardium. There are 3 types. Most of the time, cardiomyopathy is dilated, 90% of it. Then there's also hypertrophic and restrictive. Now, this cardiomyopathy content is actually in a different chapter, but I mentioned earlier that I handle it with heart failure because the symptoms parallel heart failure. Some causes: dilated cardiomyopathy. 90% of cardiomyopathies are dilated. Cardiotoxic agents. These are things known to harm the heart muscle, like alcohol, cocaine. Doxorubicin is a cancer drug. There is a genetic autosomal dominant or a familial genetic link 30% of the time with a dilated cardiomyopathy. High blood pressure can end up causing dilated cardiomyopathy. Sometimes we don't know what the cause is. That's called idiopathic. Coronary artery disease, metabolic problems, myocarditis can progress. Sometimes it's just pregnancy produces cardiomyopathy. I am aware of some ladies who have had children and have ended up on heart transplant lists. Valve disease, ischemic, and then muscular dystrophy can cause dilated cardiomyopathy. Muscular dystrophy is a muscle problem. Well, your heart is a muscle too. In a primary cardiomyopathy, the cause can be unknown. Primary cardiomyopathy, only the heart muscle is affected, so that wouldn't be the same as muscular dystrophy. That would be primary. So what happens? You get inflammation and degeneration of fibers, cardiomegaly, systolic impairment, the chambers enlarge, blood doesn't flow well through the left ventricle. It can develop acutely or it can develop insidiously, but the symptoms will be those of heart failure. Here is a normal heart during systole, contraction, and during diastole, relaxation. And here's a dilated heart. It's dilated during systole, and it's even dilated more during diastole. The collaborative management, we want to control the heart failure symptoms. Very palliative. There's not much of anything that can be done. It is not responsive to pharmacological treatment. It has a very poor prognosis. I mean, they may try intermittent dobutamine or milrinone infusions. They may try aggressive diuresis to get a handle on it, but it's much less responsive than heart failure is. You want to treat any underlying disease processes that may be impacting dilated cardiomyopathy. The bottom line is cardiac transplantation. 50% of all transplant patients are for dilated cardiomyopathy. The second type of cardiomyopathy is hypertrophic. This is the one that has the biggest genetic component. 50% of the time, hypertrophic cardiomyopathy has a genetic link, and that's an autosomal dominant link. Some other causes would include aortic stenosis and chronic hypertension, but most of the time it's just inherited. Here, the myocardium hypertrophies without the ventricles dilating. It's more common in men than women. It is the most common cause of sudden cardiac death in otherwise healthy young people. So when you hear about someone who dies of, a sudden heart attack on the basketball floor, they're a teenager or something like that, likely it was a hypertrophic cardiomyopathy that actually caused them to die. We used to call this idiopathic hypertrophic subaortic stenosis. Idiopathic because we didn't know what caused it, hypertrophic because of the thickness in the ventricle, subaortic because the thickened septum kind of occludes the aortic area, and stenosis is referring to that aortic area being narrowed. You'll see it in the picture here. Hypertrophic cardiomyopathy can cause a very severe outflow obstruction. That's the hypertrophic obstructive cardiomyopathy. You get massive left ventricular hypertrophy, rapid forceful contractions, relaxation is impaired, producing a diastolic effect, and you have obstruction to aortic outflow. Now, this obstruction to aortic outflow is not present in all patients, okay? If it's present, it produces additional problems. Here is a normal systole, a normal diastole. In hypertrophic, look at the septum. Look how thick that ventricular septum is and the ventricular wall is during contraction. And when the ventricle contracts, this is the aortic outflow tract here. And can you see that when the ventricle contracts, the net movement of blood is not very effectively going there. Hence, you have outflow obstruction because the blood has to take this turn, this funky turn. Look here. The ventricle contracts. The blood goes straight out the aorta just like it should. Here, the ventricle contracts, and the blood has to make this turn and this turn. Not a good thing. And even when the ventricle is relaxing, look, see how small that chamber is compared to this chamber? So hence, there you see the problems. This is a pathology, an autopsy. This is a left ventricular hypertrophy. This is the septum. That's your left ventricle. That's not a lot of space. Now, clinical manifestations, often asymptomatic. They may have some exertional symptoms. Dysrhythmias are not uncommon at all. They often have rhythm problems. They have supraventricular tachycardia. A supraventricular tachycardia is a tachycardic rhythm that originates above the ventricles. Okay, so it's not ventricular tachycardia, it's supraventricular tachycardia. Atrial fibrillation is another common dysrhythmia. Ventricular tachycardia, these are problematic. Ventricular tachycardia is a problem, and ventricular fibrillation is what can produce that sudden death. The goal of care here is we want to improve that ventricular filling. Remember how small that ventricle is. There's not enough room in there for blood to be like it should be. So we need to reduce that contractility of the ventricle, and we need to relieve the outflow obstruction. That can be done with some meds, somewhat. At least we're affecting contractility when we do these. Right ventricular pacing. Pacing the ventricles from the apex of the right ventricle producing a septal depolarization. I'm sorry, I'm having trouble with my words. Septal depolarization happens first, allowing the septum to move away from the left wall and reducing the degree of outflow obstruction of the outflow tract. So basically, by pacing the right ventricle in a certain manner, then you get the septum contracting, moving away, and allowing better movement of blood out. If the patient has ventricular dysrhythmias, they may need an ICD. They may need a ventricular myotomy or a myectomy where they actually surgically go in and cut out some of this thick ventricle. Septal ablation, this is done in the cardiac cath, and they put an absolute alcohol into the septal artery off of the left anterior descending artery. So literally they do a cardiac cath and they find the particular artery that they want and they put alcohol down that, and it kills some of the septum to, you know, make the tissue die. The results happen in about 3 months. It takes about 3 months for that dead septum, and not the whole septum dies, but the dead septum then to be cleaned up by the body. And they do find improved heart failure symptoms and exercise capacity doing that. Now the third kind of cardiomyopathy is restrictive. This is the least common. A specific etiology is unknown. It could be a fibrosis, sarcoidosis, you know, it could be radiation. But here you have diastolic filling and stretch that's impaired. Systolic function is not affected, so you have stiffness without thickness. Systolic, diastolic, look here. In restrictive, systolic, diastolic, it doesn't look a whole lot different between these two. You have stiffness, you have a stiff heart, but not a thick heart. The manifestations are a lot like heart failure, and when you have this stiff heart, the fluid tends to back up. They can do an endomyocardial biopsy. There's no specific treatment. Patient generally requires a heart transplant. The patient will be taught to avoid situations that impair ventricular filling. So no strenuous activity, and do not get dehydrated. All right, a little bit about cardiac transplants. How many people need and receive heart transplants? This information is from the American Heart Association. There were 2,163 heart transplants in 2008 and 2,210 in 2007, so a little more than 2,000 people in a year. Each year there would be thousands more if we had donor hearts. In our country, during that time frame, 72% of heart transplants patients were male, 65% were white. As of June of 2009, 1-year survival was about 88% for men and 77% for females. The first heart transplant was performed in 1967. I was alive then. I know many of you weren't. Criteria include refractory. Refractory means non-responsive. Refractory cardiogenic shock, dependence on inotropes to maintain organ perfusion. 50% of patients who get cardiac transplants have cardiomyopathy. 40% of them have inoperable coronary artery disease. In infants and children, most of the heart transplants are due to a congenital heart defect, and many, many patients die waiting for a heart. Other criteria: a severe limiting ischemia that can't be fixed, or life-threatening dysrhythmias that can't be fixed. But primarily we're looking at the refractory cardiogenic shock. Immunosuppressive drugs are begun in the OR. There's some examples of the drugs that we use: the corticosteroids, cyclosporin, tagrilamus, and the cell sept. Infection will be the primary post-op complications. Endomyocardial biopsies are done. Those are done, the biopsies are taken from the right ventricle, and you go through the right internal jugular to get there. For a month, those biopsies are done once a week. And then for 6 months, you get a biopsy every month. And then after that, they do a biopsy every year. They monitor T lymphocytes. And between those two things, then, they determine how your immunosuppressive therapy is going, or if there needs to be any changes. My understanding is that immunosuppressive therapy can be very expensive. Ventricular assist devices, the bridge to transplantation, mentioned these a little bit earlier too. They are getting fancier and fancier. This is an LVAD. It's pretty internalized, except for the battery stuff, comes out. This is a bilateral ventricular, a right and a left pump. So this patient's heart is so bad that even his right heart isn't strong enough to pump blood to the lungs to get it back to the left heart to pump to the body. So this is a biventricular, or a right pump and a left pump all put in together. Now, the FDA approved the AviCor artificial heart, which is the first totally implanted artificial heart. That was approved in September of 2006 for humanitarian use. The first one was placed actually in July of 2001. That patient lived 512 days. I actually have the FDA news release, September 5th, 2006. FDA approves first totally implanted permanent artificial hearts for humanitarian use. I had that in my notebook. The study that they cited showed that the device is safe and has likely benefit for people with severe heart failure whose death is imminent and for whom no alternative treatments are available. In some cases, the device extended survival by several months, allowing the patient to spend valuable time with family and friends. In 2 cases, the device extended survival by 10 and 17 months, respectively, and 1 patient was discharged from hospital to go home. Now, in time, this technology is going to get better and better. I don't know. Will the day ever come when you can go to the supply room and pick up a artificial heart? It wouldn't surprise me, but we shall see. All right, that concludes heart failure. Again, review this, review your readings, and jot down your questions. We'll make time for them.